All right, so who is very interested in talking about where to see your patients and when to start your practice? Okay. Who is very interested in how to get more referrals? More, okay. Who is very interested in how to negotiate the initial contract, set the fee with the patient, talk about schedules, about the same number there. How about keeping patients in therapy once you have them? A few less. What I'm calling the 2-year drop-off. What happens after about 2 years when people say they're better and they want to leave and they're not better. Okay. And raising fees and moving locations, changing your schedule, later on adjustments that you need to make in the practice. All right, so this one I think is the least hot topic, and this one was surprisingly not as hot as I thought it would be. So let me see again. Negotiating the contract, not as hot as I thought it would be. Okay. 2 hands. Okay. So in your folder, take out your folder. Does everybody have one?
No.
Okay, so you don't have to have one. I'll talk you through it if you don't have one. There are a couple worksheets in there. Borrow somebody's piece of paper if you don't have any. Most people have 2 blank sheets of paper in there, so pass one to your neighbor if you have 2 and they don't have any. So I'm going to ask you a bunch of questions, and just write down your first answer, even if it doesn't make sense to you. Those of you who are in psychoanalysis are going to be familiar with this method. Don't think about it, just write it down. What is your ideal practice location? Describe what it looks like, what it feels like, who's there. This actually is written out in some of your packets.
Yes.
Yeah, okay. So those of you who have it written out, just do it, and I'll talk the rest of you through it. The second question is, who are your favorite patients to work with? Not the names of them, but what are they like? 3 is, what kinds of contact do you most like to have with your colleagues? What kind of contact do you most enjoy having with your colleagues? Am I going too fast? Yes? Okay.
What would be examples of
I like to go to movies with my colleagues and unpack the unconscious subtext of the film. Name that person. I like to go out to lunch with other students on Friday and let off steam. I like to talk about cases. I like to avoid my colleagues because I have terrible feelings when I get together with them. Really, whatever comes to your mind. I don't have colleagues, and I wish I did. I'm lonely in private practice. Whatever is your actual experience. Okay, what is fun and easy for you to do in your work that might be difficult for other therapists to do? For example, you really enjoy borderlines.
Seeing people at the crack of dawn.
Seeing people at the crack of dawn, right. You're an early riser and you're willing to see people at 5 or 6 a.m. before their workday. And that's when you'd rather be awake, yeah. So the reason I'm asking this question is it's relatively easy for me to deal with money. And I don't exactly know why that is, but I noticed early on that it was relatively difficult for most therapists. So when I offer a program or something like that, I offer something that has to do with that because it's easy for me and I know it's desirable. It might be easy for you to see couples or, something like that.
Does it have to be a population?
No. It might be easy for you to, what else? Getting up early. Are people having trouble thinking of something? Okay, skip it.
Weekends.
Yeah. Weekends, yeah. It's easier for you to work on the weekends, yeah. Okay, who would you spend more time with if you had more free time? And what would you be doing? You would be rock climbing. You would be on the crew team. You would be at the movies. You'd go back to school. You would take a class in something that you knew nothing about. What's the most difficult thing for you to do or to think about doing in private practice? What's the most difficult thing for you to do or to think about doing in private practice?
Is it on the list or you just?
Isn't that on the list?
Yeah, the last question.
Is it the last
Oh, no,
question?
off the left.
Oh, maybe I left that
No,
off.
it's there.
Oh, okay. So, if you're not thinking of something, it may be the most difficult thing for you to do is even think about it. You could say, I can't even think about it. I get too anxious. I'm sure I can't do it. I can't think of a thing. Or something like that. All right. And by the way, I'm not collecting these. No one's going to see them. What groups of people do you have specific knowledge of? Just because of your personal experience. So examples I thought of are athletes, artists, biracial children, psychosomatic patients, ex-Catholics, perfectionists, engineers, former gang members, etc. You've had experience in your life, Taekwondo practitioners, you've had experience in your life that gives you special knowledge about types of people that might help you in building a practice. International students, people who have come from a different country or culture or that kind of thing is important. Okay, so on your other blank sheet, draw a line across the middle of the paper. And above the line, write down anything I say tonight that you think would be a good idea that you'd like to remember. And underneath the line, write why you're not going to do it. Is that clear? So you know what sounds good, and you're going to write down something that alerts you to what your resistance is to doing that particular thing, which we can use later. Any questions so far?
Can you repeat the question?
The last one?
Oh, it's the last one on here.
Oh, yes. Name as many reasons as you can in the next 2 minutes that I'm going to allow you why you cannot possibly succeed in private practice without insurance. And if you run out of space, turn it over. Why you can't possibly succeed at being in private practice without using insurance. Just doesn't have to make sense, just whatever comes to mind. Hi. Did you just get here, or were you? Oh, okay. 30 seconds left. Well, you can't possibly do it. Okay. All right, so this is what I did, and I did this. Was anybody in this private practice workshop that I did like 15 years ago or something? No, okay. So I don't know how long ago it was, probably 15, and then maybe even 10 years before that. So this is like the third iteration. So what I do is go in my date book, and I look at everybody that I'm currently seeing in therapy or in supervision, and I try and trace where they came from, how they heard about me, or if they knew me from school, why they asked me to treat them or to supervise them. And some of this is guesswork, but some of it I know for sure. So now I'm seeing a total of 32 people. These are analysins and supervisees. Some people I see more than once a week, some people I see less than once a week, but that's the average. That's the total number of people. And the average hours, depending on whether it's a class week or a non-class week, between 20 and 30 hours a week. So this is very different for me. I used to work considerably more hours than this. And when I did my research into my date book the first time and the second time, I found that the people who had referred someone to me, in other words, a person who didn't know me personally, they had one thing in common. The referring people had one thing in common. They had recently been to my house for dinner. So what do we make of that? When you put it in the context of the other things that I'm going to tell you, it has to do with spending more time with people you love, actually. Doing things you love, spending time with people you love, making yourself happy, and spreading that around. And I was not, by the way, I was not having dinner parties in order to get referrals. Of course. I know people who've tried that, and it probably works, but this was not the idea. The idea was I love cooking, and I like having people over, and this made me happy, and I evidently made them happy, and they wanted to give me something back. And that's what, I mean, they also had me to dinner. But.
Could we use your food?
Whatever you love doing, and whatever you love doing with people, do that. Do more of that.
How many people? Sorry, I'm trying to know, for every time you kind of have a dinner, how many people will be invited to there?
At the time that I studied it then, you know, between 2 and 6. It was small events. Sometimes I had a big party, but I don't think that was it. I think it was actually sitting down to a meal with people. And I was very surprised at that. The second thing I found was that my pediatrician, my children's doctor, started sending a lot of referrals. Most of them never called, and I know this because I called her up. The couple of people who did come and who did stay, I called her up to thank her for the referral, and she said, "You have to be kidding! I've sent you, 30 people, and only these 2 people have called you." And then I realized that physicians need to be trained in how to make a referral that sticks. They don't actually know how to refer a patient in order for them to stay. So one idea I had, if something happened in my practice and I needed a big influx of people, what I was going to do was package a little workshop for small medical practices where I would go to their in-service location and give them a little bit of training about how to make a referral that sticks. Which I never did, but I think it's a good idea. So anybody who wants to do that, try it.
Dr. Wagner, just back to your dinners for a second.
Yeah.
I assume you didn't literally talk about your practice. It was just more the conviviality, and they loved you, and they thought she seemed like she'd be a good therapist kind of feeling? Or?
Well, I think I do talk about my work because I love my work.
Yeah.
So that's another thing. Structure your work in a way that makes you really happy. Do what makes you love it. Mm-hmm. And then you want to talk about it. So I think I probably was talking about my work as much as any other thing. Mm-hmm. I wasn't aware of it.
And how to make the referrals?
How did they make the referrals?
Yes.
They would tell the person, you need to see Dr. Wagner. She's whatever. Mm-hmm. She's going to really be able to help you. She's going to, I don't know what.
And what's the right way to do it?
Oh, for a pediatrician?
Like for any
For
medical practice?
For a medical practice, the right way to make a referral is not to dump the patient on the therapist. So the patients who give physicians the most trouble, I think, are psychosomatic patients or patients they can't help, people who are frustrating them. And I think parents of children who are very ill. So one other idea I had, if I needed a big influx of referrals, would be to run a group for parents of children with a chronic illness. Mm-hmm. These are people who are dying to talk to each other and really need a lot of support. And physicians need to be able to send them to someone who's going to help them. And these are kinds of people who want to be with other people like them. So it would be easy to do a thematic group for people like that. And you can do like a 6 or 8 or 10 session thematic group, let's say for parents of children with a chronic illness. And then maybe 1 or 2 of those people will want to see you individually, or maybe the group will want to continue or something like that, because they'll already have met you while they're being with each other.
But do they pay for the group? Or?
Yes, they pay for the group, yeah. So patients don't want their physicians to dump them. They want to know that they're going to continue to see the physician. So the right way to make that referral is call this therapist, make an appointment, meet them, see how it goes, and then come back on Tuesday and tell me how it went. And on Tuesday, when they come back and tell how it went, it either worked or it didn't, then they have to find somebody else. Usually, if the person knows that the physician has confidence in the therapist, and is not going to dump you, you're more likely to be able to make that connection.
Along that line, there's some people that have the idea that a doctor making a referral should give the patient 3 people's names.
No,
Right.
one name. One name that they have full confidence in. It's the feeling that the patient is getting from their physician that's going to make them go out on that limb.
It's hard to tell those physicians
Right.
that one person is better than
Right.
a handful.
Right. And, all the whole insurance thing. People want to use their insurance, and we're not even talking about that. Okay, so 11 of the people that I'm seeing now came to me from word of mouth. So someone told them to call me. 11 are BGSP students and graduates. So these are people who will have seen me in the hall or had me in a class or met me through the admissions interview process or something like that. 4 are from a prior organization that I worked with. 3 came from common interests. So that's why I'm asking you on this worksheet, what are you really interested in doing? Do the things you want to do with people and enjoy doing those things. And when your work comes up, talk about it. Let them know what your life is like, what your work is like, what you like about your work. And that will be just on their minds as a part of being with you at rock climbing or wherever, at the gym or something. 2 came from a workshop like this, and 1 came from an outreach from a course I did at another place. And then I did those, looks like a family tree, who sent who and who was related to who and all that. So 13 of these people came from cooking or what I would call other acts of love, like volunteering. So volunteering for your friend's son's cancer bike ride money-raising event. Giving a fee workshop. So I started doing this fee workshop for my psychology school because they were calling me for donations like everybody does, and I didn't want to give them a donation because I was already here and I wanted to give my resources here. So I thought, okay, I'll do a workshop for them in their continuing ed department and I'll donate the fee. So what I'll get out of it is feeling like I've done something for them. I won't have to feel guilty and selfish, and they'll get the money from it. And again, I wasn't thinking of referrals, but each time I've done a workshop like that, literally each time, someone has called and said, can I see you for this, or I have somebody for you to see. It doesn't always work, but it always has happened. So be generous. 1 came from the coffee shop. And I couldn't figure this out. So Athens, the old manager from Athens, never would charge me for coffee. She's not there anymore, so the new people don't remember her. But she would never let me pay for coffee. And I went there every Thursday. And I finally asked her why, and she said, "You don't remember." And I actually remembered the event. I just didn't connect it. She had been having trouble with a customer. The person was in some kind of a confused state and didn't have money and was getting very upset, and it was, a legitimate mental health crisis in the coffee line. So I said so those of you who are in school here know the object-oriented question drill. I had to find a way to say this which didn't reference this customer. So I said something like, "Oh, that coffee is on my bill." So I paid for her coffee, and I don't think I was charged for my coffee, but I don't remember. And we went out and sat on the bench for a while out in front of the coffee store. And that manager was grateful forever and never charged me for my coffee, and furthermore sent me a patient, which I couldn't take, but That's not the point. Giving credit, so Ms. Moore, your question about do you talk about your work, another example was one day I was in a really great mood. I was in the flower market. Even when I was in graduate school and I was super broke and, I had no time and everything, I had flowers in my budget because flowers make me happy. So I was at the flower market and I was in a great mood, and the people there knew me well. I was often in there. And they said, what's making you so happy today? And I said, psychoanalysis. Whereupon, they looked at me like I was crazy. But that started a conversation about my work. So then, the flower vendors, who were this couple, you remember them, this was back in the early days, knew about my work and would ask about it and became very curious. So this is how it works. Bring your happiness in your work where you go, and it will spread. Give referrals to your friends. If you can't take someone, pass them along. Okay, so that was 13 people came that way. And then another 9 people, I would just say it just has to be transference. I don't really know. So these are people who had already met me and got a feeling from me that they wanted to work with me. And it could be a variety of things. And the 5th, the last one, I would call niche transference. So that's why I'm asking you what you have special knowledge of, or what is it about your own experience that is unique. International students tend to want to work with me in greater numbers, I think. And I think it's because they either know about my own international status or they intuit that. Without being told. So my father is from India, and my mother is from America. And so I have this kind of bicultural vibe or something. So that's enough about my research into my practice. Any questions at this point?
It doesn't sound like you ever sent out a letter to friends saying, I'm opening a practice, and this is going to be my specialty, or whatever. You didn't ever do that.
I would if I had to. But so I was lucky to start out in the counterculture days where there were many practitioners who were working without insurance. And it was largely starting out in groups. And I learned how to negotiate fees on a sliding scale early on. And I just thought that's how it is.
What about websites?
I don't have a website. If I did, I would go on Psychology Today. So let's talk about referrals. I think the way that people most get referrals now is from Psychology Today. Correct me if I'm wrong. Is anybody getting any website or social media or any kind of referrals from a different source other than that? Like, does LinkedIn work better? LinkedIn?
But it's not even close.
Not even close. So Psychology Today is still the highest. Anybody else have a different view?
I think that's because people go to psychology.
Right. People go to Psychology Today when they're looking for a therapist. So when you're making your profile, present yourself the way you really are happiest in your work. So if you really enjoy working with artists, put that on there. Because everybody is going to say they work with anxiety and depression and yada yada.
How about young adults?
Yeah, young adults. And even consider doing a group for young adults, because I think other therapists go on Psychology Today and look for things like groups or look for referral people to treat someone that they don't have any expertise with.
What's wrong with taking insurance?
There's nothing wrong with taking insurance if you want to. I don't want to because for me it's paperwork it's an interference. It's somebody between me and my patient. It's not enough reward for me. It's too much pain and not enough reward. I don't like to, and I don't like the confidentiality issues. I don't want someone calling me up and saying, you know, you're out of your patient's sessions. Why do they need to keep seeing you? I want to say it's none of your business. But there's nothing wrong with it if you want to do it.
Just that I'd add, and I'm sure some people already know this, but Blue Cross actually has let go of the need for authorization, and they've approved for longer sessions. This all happened in the last 2 months. So it's kind of a big deal.
It's a very big deal, and it's a good transition strategy, right? So if you're already in practice and you're using insurance, or if you're already at an agency and you want to leave the agency and start a private practice, you may want to consider a couple of insurances that reimburse well and don't have all these limits and you know, don't pry into your patients' lives and stuff like that. And also develop your private pay patients on the side. So you might say you're taking this kind of Blue Cross, or some people, like I was talking with another person today who lives in a rural area where a lot of people are on Medicaid, and evidently they're paying better these days than they used to, and he wants to be able to treat them, and so he stays on Medicaid, but not other forms of show. He has a private pay practice with, you know, this one company, and there's also nothing wrong with that. And, you know, a strategy of building a practice while you're still at a clinic or an agency or something like that, you need a transition.
Do you invite people back for dinner after they become your patients? How do you set up boundaries from person?
Oh, okay. I haven't been clear enough. The people who came to my dinner are not my patients or my supervisees. They're people who referred me a patient or a supervisee. Yeah. Some modern analysts are trained to treat people that they have known in their life before, and that's a particular thing that's possible. I haven't done that, and I don't want to. I'd rather keep my friends my friends.
One population you haven't mentioned that I've been working with since the early 80s was the older adults.
Yeah.
And I have been a Medicare provider for many, many years. The reason that I'm no longer going to accept Medicare is that I had not been paid 1 penny from Medicare from April until last month.
Yeah.
That's almost a year.
Yeah, it's horrible.
And I know it's only going to get worse. And it's been really hard because I was going to places from here. I wasn't working here, but I was working in Rhode Island.
Mm-hmm.
My clients in Rhode Island, first of all, most of my clients are in their 80s and 90s. They are not going to pay me out of pocket.
Mm-mm.
And here, being here now, I can see that the population in this area is much more willing to pay out of pocket. So I'm trying to build my practice here now. And I have been reaching out to make some referrals. My doctor's office, they were very enthusiastic to take my card because they have social workers that work there, and then they would refer out after like they meet with the patient because the doctor can just is overwhelmed with their anxiety.
Right.
And but I haven't had any referrals, and I don't expect it to just happen. But so that's been a big challenge for me. You know, leaving my practice in Rhode Island, making referrals for other people, and actually one of my clients there is willing to pay out of pocket. She's like in her early 70s, so that's not an issue with her. She's not overwhelmed with it. The rest of them do not. I didn't even tell the rest of them. Some of them, I had to stop working because of a health reason for a while, so I was out of commission. and they did, but I have, but the way that the people that I'm referring to, unfortunately, I do not really want to work with older people.
Yes.
Because it's a whole other ballgame.
It's
And
it's
you have
difficult.
to be willing to also help them connect to people,
Yeah.
connect to agencies. One of the referrals, one of my clients was willing, but I'd spoken to the therapist, and she said, no, I don't think he's too happy with me. I said, are you helping him to refer? She said, oh, I'm not going to do that. But I had my master's in gerontology before I went back to social work school.
Mm-hmm.
So that's kind of what I'm dealing with now. What? Home, and I
And
do
home visits.
home visits because I worked for an outpatient mental health agency for 20 years where there were 6 of us that were older adult people, and we did only home visits. And you learn, when you talked about the challenge, I like doing home visits. You learn a lot more what's going on in that home.
You sure do, yeah.
And I also have a difficult population with big, it was hard, grandparents raising grandchildren. And some of them are in their 80s, and that is not easy. So the whole thing with Medicare, and I guess one of the things I was hoping to learn, and it might not be tonight, is if I do start it, I have to let Medicare know that I'm no longer accepting it. So
Yes, you
I
do.
just do that.
Well, I don't know. Do you, or you could just?
You
could-
when you say I am no longer accepting insurance.
Does anybody know the answer to that? I don't actually know. You could do that, and you could also just stop taking Medicare and tell anybody who calls you who has Medicare that I've stopped taking Medicare, and then you de facto, handle that.
There's a form. There is a form you can get through Medicare. I don't know if it's still working. That was where somebody could to give the client a documentation that says that you saw them, what their you give them a diagnosis, what the code was, and all that stuff, and then they can send that along to the form with Medicare. If Medicare sees that the person that sent, that the provider is seeing them, they might say, well, this person's supposed to accept Medicare.
I see. So you better
I'm gonna have to
unregister.
find that
Yeah,
out.
yeah. Well, there's
It takes
no
about 3 months to
to get
get off.
off Medicare.
To get off of it?
To get off, yeah.
That's fun.
So during those 3 months, you still have to accept by.
Oh, that's interesting.
But you could say you have no space left.
And you don't have any
Cuts down your
space
hours.
left. If you have decided to no longer see Medicare patients, you actually don't have any space left
Correct.
for that person who calls you with Medicare. That's the truth.
Yeah.
You have a right to see people who you want to see and not see people who you don't want to see, right? What were you going to say?
Oh, I thought of another resource from 2 colleagues in New York, and it's in gyms, there are physical trainers now, and they work very closely physically with people. They often get into psychological issues without either knowing, or they get scared, and so they have gone in to meet with physical trainers both in their own gyms and other gyms, and they get referrals now from the physical trainers. So I don't see any reason it couldn't work in Boston. They've done it in New York.
There are a lot of groups of practitioners, bartenders, hairstylists, real estate agents that people confide in and tell their problems to, or reveal their problems in action, right? And who are not really trained to deal with them and themselves get in over their heads. And you can consult to those people and help them work through whatever is going on with that particular client. Or you can say, when they're, just talking about it, you could say, oh, that person needs to see me. You need to send that person to me.
They left the trainers their cards, so they referred it. Whenever they get somebody who seemed like they'd say, I can't really deal with this anymore, why don't you go talk to this person? It really was a very helpful resource to them, as well as built the practices of these 2 people.
The other thing to consider is treat children. young adults, people who are languishing on waiting lists because they can't find someone to treat them. And if you don't have specialized training in treating children and adolescents, consider getting that and starting your practice with children and adolescents who really are having a hard time finding somebody. You do have to do a lot of collateral contacts, work with the schools, work with the physicians, with the group home, with wherever. But that's another way that you're going to meet people who also might want to send somebody to you, or who might want to be in supervision with you after you talk through with them the special difficulties of this certain person or this certain situation. They might say, oh, can I talk with you about this again? And you can schedule a consultation with them.
There are, if anybody's in this area, there are really actually no groups or social activity groups for adolescents around here, even though Mass Mental Health has some. I just got a call the other day for younger adolescents, 12, 13-year-olds.
Mm-hmm. So, if you're not a specialist in that, but you're good at program development, and you know somebody else who's trained to work with children and adolescents, team up with them and come up with a program. Put your heads together and work together on something like that. Find somebody who, if it requires a license, find somebody who knows how to do that. Being in a group practice is an alternative that appeals to a lot of people as well, because you can advertise differently than you can when you're in private practice. You can advertise as a group, you have a name, you can do things that get you your group name recognition. You have a certain amount of collegiality. You can share office space, so it becomes cheaper in that way. You can have a day and a half. They can have 2.5 days if they already have that many people. There are ways to set up a practice that are less financially confrontational at the beginning. Sublet somebody else's office for a little while. Or get an office that you love and furnish it in the way, this is my strategy, furnish it in the way you really like. You're going to be in your office so many hours a week. Make it the way you really, really want it. And then when you're not there, sublet it to somebody else who's starting a practice. And then that'll help pay your initial rent. What other questions about referrals?
I'd like to hear your thoughts on negotiating fees.
Yeah. So I was trained in different strategies for negotiating fees. One strategy that I like is to, as you're in the intake session, as you're getting a sense of the person and what's causing their suffering and how it would be to work with them, and whether you seem to feel like a good fit with them or not. And if it seems like you want to work with them and you would be able to help them, you can say, among other things, what did you have in mind for a fee? Usually people are surprised at that question. But they do have something in mind, whether they know it or not. They have an idea of what they would be expected to pay and what they want to pay and so on. So, just opening up the conversation in that sort of matter-of-fact way and trying to not be too anxious when you do it, which is, the first 25 times you do it. Most therapists are very anxious negotiating fees, so you really have to practice how you're going to do it and try and calm yourself down, just breathe and all that. So the person might say, well, I had in mind, I don't have a lot of money, and maybe, maybe it's not enough or something like that, but I had in mind $25 or something like that. So you may be able to, at the place that you are in your practice, to take them at that fee. You might, on further discussion, feel like that is the right fee for them. Or you might think that's not going to work for you, but maybe you could work for $50. Maybe you could work for twice what they're saying. And so you might say, well, if we saw each other, you can say, how often did you have in mind to come? Usually people say weekly. So you might be able to negotiate to see that person every other week to begin with at a $50 fee. That is a very common and very effective strategy, and a lot of people, if they want to work with you and they're getting the right feeling from you, are able to start that way. And then as they're doing better, and you can help people earn more money as part of the therapy that you're providing. And as they're doing better, you can raise their fee.
Back up a bit.
Mhm.
Most people have insurance from their job or school or some kind of other thing. How do you even have the conversation about them not using their insurance when they do have insurance?
So I try and say it in a way that doesn't reference them, but talks about me. So this is called, in our psychoanalytic lineage, it's called object-oriented questions. So you talk about not the subject, which is them, but the object, which is you, or their spouse, or their parent, or whoever is going to be paying. And you say something like, well, I don't take insurance, but maybe we could work out a fee that's affordable to you and that would work for me. And often that's a new idea for people as well. So I read a lot of articles about fee setting this time, and I discovered several things about that. One is that in the 80s and 90s, people were writing relatively more about this than they were before or since. I don't know why that is, but in those decades, there are several psychoanalytic articles published about this topic, and also I looked in the psychology journals as well. So I'm going to give you the titles of some of these, and I'll pass them around. You can see my highlights. These are my only copies, so send them back up here. But one is called Psychoanalyst and Psychotherapist Conflict About Setting Fees. This is Ella Lasky, 1984. I thought it was kind of so-so. One is called Show Me the Money, The Problems of the Therapist's Desire, Subjectivity, and Relationship to the Fee. That had a lot of interesting points in it.
Who wrote that?
That is Kachina Myers. That's in Contemporary Psychoanalysis. Myers. Contemporary Psychoanalysis, 2008. This is, I think, the most recent one. The best one I thought was Muriel Diamond, Money, Love, and Hate, Contradiction and Paradox in Psychoanalysis. There's some really good case examples in here of how she worked with the hatred and outrage that came up in a patient of hers when she changed her office and looked relatively more affluent, and the patient really came forward with all kinds of negative feelings and hostility. And this analyst did a really good job of working that through, I think. So I recommend that. That's Psychoanalytic Dialogues, 1994. And then this one is relatively recent, 2011, from Contemporary Psychoanalysis. It's The Good Job, Financial Anxiety, Class Envy, and Drudgery in Beginning a Private Analytic Practice. So I'll send them around separately, and you just glance at them, and you may want to look more into that.
One question. Does doing research and publishing papers increase influx of the patients?
Yes. One way to get yourself known is to write, or to have a podcast, or to share your ideas in some kind of format that spreads. I don't know anything about social media, but I bet most of you do. So you can use that as a way of, even sending out small thoughts about something that you're learning in your work, or something that you read that really struck you, will keep you on people's minds, and will, if they're interested in what you just sent them. Someone recently sent me a wonderful letter that Agnes DeMille wrote to Martha Graham back in the day, and it was so beautiful, and then I sent it to several people. Not, again, for the purpose of referral, but then it did spread around, and someone else that I hadn't sent it to contacted me. So there are a lot of ways you can write for, I don't know, are there newspapers anymore? There used to be something called the Parents' Paper, for example, that people would leave around. Where else can you write? Newsletters. Yes, I think writing is a good example. So we have a blog, the tab, yeah.
I've been doing a blog for about 60 weeks about my private practice. In about 4 months, it got me to about one new client a month, And I also do a podcast with another analyst, so that's also helped. So I knew it would take some time, but doing it weekly and consistently, and also getting email lists and doing emails out, that's been pretty useful for the start.
Yeah. And you just know how to do that to begin with, right? Did you have to learn?
I just watched a lot of YouTube videos.
Oh, there you go.
Show them how to do it.
Yeah.
You can hire someone to make a website too.
Uh-huh. Let me just finish answering a fee-setting question. Another way that another supervisor taught me, and by the way, another really important thing is stay in supervision longer than you think you want to, longer than you think you need to. Just stay in supervision, stay in training, get new information, and I'll tell you more of my sort of thoughts about that later. But another supervisor said, I ask 3 questions negotiating a fee. So these are the id, ego, and superego questions. I forget the order that he asked them in. But they are, what should you pay? What do you want to pay? And what would be the right fee for me to charge you? And that's the one you want to go for. The person should be paying a fee that's meaningful to them, that they can actually afford. It may be a little bit of a stretch for them, but you are likely to be the most important person in their life for several years. So the fact that it's a little bit of a stretch for them to come and see you is appropriate in terms of their priority of taking their therapy adventure seriously. It shouldn't be too high, and it shouldn't be too low. And it shouldn't be either too high or too low for you. It should give the patient and the therapist the right feeling. Yeah.
Is there a negative to having what we call a standard fee that you normally work within, and then having a sliding scale back to the extent that you feel that particular patient can't afford or it's not appropriate to them?
A lot of people work that way, and actually the research suggests that more men work that way than women. So this was an interesting thing that I found reading these articles. So people who looked into this found that male and female therapists are both uncomfortable dealing with money, but women are suffering more about it, and they're charging universally lower fees than men are charging, that they're more likely to have a sliding scale. I mean, this is not a surprise, right? But it's still that way. They're charging lower fees. They're less likely to have a standard fee. And they're, I already said, they're suffering more about it. So, the cultural factors being what they are, we're still working on these kinds of things.
It seems there's so many pieces to establishing a practice that if you could standardize it to some extent, it seems like it simplifies the process.
Right. Standardizing it in your own mind is important. And again, at different stages in your practice, like if you're putting your kids through college, for these 8 years, you're not going to be taking low-fee people. If you have an open hour, you're going to be taking somebody for a high fee. And you may just refer 6 or 7 people to somebody else while you gnash your teeth and wait for somebody who can pay a high fee. But there's nothing wrong with having a standard fee if you're comfortable that way and you're willing to refer people on who can't pay it or see people less often. I see someone for a half session every other week. but the whole fee would be $100. So it's two $50 half hours a month. And it works. It's a maintenance, it's not a curative dose, but it's a maintenance dose, and it works for that person. That's another thing you can do. If someone loses their job, or, they're going back to school or something, and they're in worse financial condition and they want to cut back the fee, you could see them for half sessions. You could see them less often. You could reduce the fee, but if you're going to be doing that, I would talk it over with a supervisor or a consultant first to see how that particular person's money issues may be a clinical issue, or maybe a countertransference issue. So there's the patient's history with money, their transference, how they're experiencing you. There's your own history with money, your own insecurities and anxieties, defenses that you have about it. And then there's whatever clash in the middle of those things. But very often, patients will induce the therapist emotionally with not only their major conflicts, but whatever they have going on about money, which gets into issues of esteem and status and respect and all kinds of things that are really close to the bone. Money is symbolic of these kinds of things.
Would that help you, like giving the patient half a session help you, or is it just therapeutic for patient's benefit? Because you can't use the other half of the session.
You can use the other half of the session to do things that you don't have time to do if you're working back-to-back sessions. You can, return calls or something like that. But it's true, though, if you have, at a certain point, time is money. And at that point, a half an hour in your day is really valuable. And therefore, it doesn't feel like much of a hardship.
I have another question.
Mm-hmm.
That's all right. So how do you think about offering a higher rate? So, this is something I've been experimenting with recently.
Mm-hmm.
If you suggest that the patient pays more, they think that you're a better therapist.
Yes.
So how do you think? What do you think?
Yeah, if you are comfortable quoting a higher fee, it's very likely that the person you're talking to is going to think you're worth that higher fee. And you probably are. If you're comfortable saying that, you're probably going to do what it takes to be worth that much money.
Yeah, I've been trying that recently, and it really works. They think, this is really, it's going to be difficult for me, but it's worth it. I'm going to make it happen.
Yeah.
But I don't know how long they're going to leave in 6 months because they're broke, or...
Well, if it's really too much for them to pay, I wouldn't agree to it. So, you ask further questions. If the person says they can pay $100 because they think they should pay, and that's an average private practice fee, then they really might not be able to afford it, and they might not know that at the outset, and they may run out of their resources and not be able to see it. So you should arrive at a fee that's actually sustainable for them. And then you run into issues like, what if the person is a college student and their parents are paying for every other thing about their life, including their Starbucks habit or, their vacation to places you would like to be going to, but they want to pay their own psychotherapy fee. There are issues like this that, once you inquire into it and you know more about their circumstances, those become clinical issues.
Before I recommended a friend came to our therapy center, and he's a BC student, and he used to see a psychologist who charged him $200.
Mm-hmm.
And when he came to our therapy center, I don't know how he heard about other people pay like $20, and he said, he considered us as less authority.
Yeah.
And I think he did say something like, I feel like psychoanalysis works in a different way,
Mm-hmm.
and I do feel more comfortable, but I still feel like you guys just I don't know, feel like less often.
Yes, that's a fee that is way too low for that person. It's not meaningful. It means the wrong thing. And it should be, if he's seeing a brand new therapist who shouldn't be charging $200 at that point in their career, maybe something in the middle of what he's used to paying and, what a conventional copay would be a more appropriate fee for somebody like that. It has to have the right meaning. And, sometimes it takes a while to figure this out. And then what if you agree to the wrong fee? Then you have to say, again, referencing yourself rather than the person, you could say, I wonder if I was too hasty when I negotiated the fee with you. It seems like maybe, this fee is, not the right one. Yeah.
Have you had a situation where someone comes multiple times a week, and how do you base the fee on, or do you lower the fee because it's multiple times?
No. I usually get the person up to my full fee or what I think is a fully appropriate fee for them before I add more sessions. And that's for reasons, again, of the meaning to the person. It's actually insulting to a lot of people for you to lower their fee. Even though on a conscious level it feels like a kind thing to do, it communicates many times a disrespectful attitude. And it may also communicate the therapist's unwillingness to deal with the negative feelings that are aroused when they want you to reduce the fee and you don't do it. So when I see people multiple times a week, it's usually because they're doing better, and usually when they're doing better emotionally, they're doing better financially. So it's better for them and it's better for me.
You mentioned that you sometimes that you discuss the fee at the first session.
Mm-hmm.
So what do you do about getting paid for that initial? Don't they ask you on the phone or anything like how much you're going to
I usually say I don't usually negotiate fees over the phone, but I'd be happy to talk about that with you when we meet.
So, okay. And that would include your first session.
If I end up working with the person, I charge them whatever we've arranged for the first session.
Mm-hmm.
If I don't end up working with them, I don't charge them.
Okay.
If you charge someone money, that's a commitment. Does that make sense? So even if you're doing an extended intake and you find out the person is a stalker, this happened to me once, don't take any money from them.
What if somebody asks why? Why wouldn't you discuss the fees over the phone? What would you say?
It doesn't work for me.
It doesn't work.
Yeah. Yeah. Talk about yourself. Just be very matter of fact. I've found that doesn't work well for me. You might lose the person, but people who want to talk about fees on the phone, think about it. Have those been good patients? Not necessarily. In my experience, not necessarily. It represents a hesitation, a kind of, ambivalence, a reason to rule you in or out that has nothing to do with you. It's a pre-existing kind of a thing. So we have about 45 minutes left. How are we doing? Keeping patients in therapy. So there are a lot of early resistances after you make the contract, in the first, 6 months, even maybe longer. There are many resistances that come up that if you don't resolve them as they arise, could end the treatment. So these are called treatment-destructive resistances, and those are what to work on first in order to help the person keep coming. So the person might say, oh, my work schedule changed. I need a different appointment time. This is a very common problem. The person contracts with you, and then they get really cold feet, which expresses itself in a lot of schedule problems.
Excuse me, what about the contract? What does the contract state?
The contract consists of the fee, the time that you're going to see them, and the activity that's going to be conducted. So the type of therapy that you provide. So, for example, I'm an analyst, so in the contract that I make with my patients, they're going to be using the couch. They're going to be trying to say, eventually, not in the beginning, but whatever comes to mind. They're going to be expecting me to try and understand the unconscious subtext of everything and help them make sense of their lives on that level. I'm going to come on time. I'm going to apply myself to this job and so on. So we're agreeing on this, to do this thing together.
Is there a minimal number of sessions that you agree for?
A minimal number of...
So if you, for example, after the third session, he wants to drop, you see, like, no fast results,
Yeah, I let people go if they want to go, unless I think it's dangerous, or unless I think that if I fought to keep them, they would stay. Some people threaten to leave because they want to find out if you really want them. And it's better to fight for somebody like that. But if somebody doesn't want to work with me, I just let them go. That's up. I don't think they should have to work with anybody they don't want to work with.
Like my friends in Russia, they have a rule to make a contract for, like, you come for they make a contract for initial 6 sessions.
I think that's not a bad idea if the person is very new to therapy. Can you hear the question in the back? Okay, you did. Okay, so it's not a bad idea to contract for a certain number of sessions if you think that the person is very unfamiliar with what therapy really is, and getting a sense of it is going to help them figure out if this really is for them or not.
Especially in group work.
In group work, you do that. Yeah, in group work you would do that because you can't replace a group member who drops out. And that's why you charge group members whether they come or not, even if they give you plenty of notice. You can't just plug somebody into that slot. But I don't know anybody who's done that. But if it makes you more comfortable and you feel like it will help the person stay long enough to get a feeling of whether they want to work with you, that's fine. Okay, so treatment-destructive resistance is they want a different time, they don't want to pay, or they forget to pay, and it's like 8 sessions in and they haven't brought you the check. What other treatment-destructive resistances? They miss the session with no notice, they come at the wrong time. All of these things are really important to resolve right up front, and to inquire into them what you might have done that caused this, or what you might do that would help it, rather than confront the person about their own behavior. People are not ready for that kind of thing when they've just met you. They don't want to know that they're acting out. But you could say, maybe I said something last week that offended you, or if that's your theory about what's going on, or wow, I must have been really scary. Something that gives them an opening that they could talk more into. So again, if you are in a situation where you're taking a bunch of new people, you're going to have a lot of people in treatment-destructive resistances. My advice is even if you don't want to have an ongoing supervisor, get a consultant for that phase of your practice who will help you keep people, because attrition is a big part of not having a thriving practice. And if you want to work with the person and you think you can actually help them, helping them feel comfortable enough to stay with you is a big and important part of the work. Similarly, there's a 2-year drop-off, about 1.5 or 2 years into a treatment. Very often, the person wants to leave. Is anybody at that phase of your practice where you have a bunch of people right at the 1.5 or 2 year mark? You are. Okay. So what's happening? Is this happening? Are the people saying, I'm better, thank you very much, I'm out of here?
They find great excuses to not come in, and there's some reemergence of all the treatment destructive. Didn't we talk about this? But it comes up again. It seems like an opportunity to recalibrate a lot of what's going on.
It seems to be a time when if you and they can do deeper work, that's the point at which it's going to start. About 1.5 or 2 years into it, and it's often sort of puzzling and scary to people. They're not exactly sure what their problems are anymore. What you could really do with them. Some people who are in more of a narcissistic state when they first start with you might never have asked you a question before, and they might have just sort of been talking, and suddenly you're in the room and you're there and you're a presence for them, and it's horrifying. So there are many things that go on at that point. And again, if you have a lot of people at that point, I would say get a consultant, find a peer group of people who have been through that, or go back into supervision with somebody you've been with before, and case by case look at what's going on for this 2-year person and see if you can help them stick.
I'm not sure that if the patient wants to leave, it's a bad thing, because if he's a whole new person, if he changed, if he reached some goals, why not? Why do I need to keep him?
You only need to keep him if you think that he's actually better off staying with you, or if he's actually running away from something that's really important and that he came for help with, such as relationship issues, right? And if you truly want to work with him, and if you feel equipped to take him deeper. If none of that is true and the person wants to leave, it's a good opportunity to let them leave you rather than sort of run out of what you think you can do for them. It's not a good idea to want the person to stay more than they want to stay with you.
Yeah, just the only reason I keep them in practice not to run out of patients. Don't think it's a good idea.
No, it's pretty unethical.
Yeah.
But it's tempting, right?
Oh, maybe. I know these people. I know what they want. I know how to make them happy, so they can pay me more.
Yeah,
so
it's very
but
tempting.
It's kind of not what I want.
Yeah.
Not what the main goal.
Yeah, you'd have to hate yourself for doing that, right? It's not worth it. Did you?
If I can just go back to retention for a second. My practice is in Brighton, so I work with a lot of students, which I love, but it's not a lot of consistent work because they graduate, have summer, winter break, and all of that. And so I've always I'm not sure how much I should be reaching out to them after like the summer or the winter, for example, to kind of re-engage, or if I should be letting them come to me. Do you have any?
I would keep them on Skype or on the phone even while they're away from you.
Okay.
So I would ask the person, the student, did everybody hear the question? What about student vacations? I would ask a student, should I offer you Skype sessions while you're home on vacation? And again, you're not saying, would you like to stay with me on the phone? You're saying, should I offer you this? And usually that will surprise people. They'll be surprised that, you would work that way. And it's a good idea because it preserves the consistency. Students have a lot of suffering when they go home. They need you when they're there.
That never occurred to me, so thank you.
Yeah. Keeping somebody on the phone is, I have people calling me from many foreign countries now who came to school here and graduated and want to keep working with me.
There's another part to that question, though, that I think you're asking, and I've worked with the college-age population, too, and there's certain people that I could tell want me, like you were saying, want you to really kind of chase after them if they've been away and they couldn't be Skyped or whatever was going on. And there are others that are trying to get rid of you, and it's just too difficult sometimes to... So it's, again, the thing you're talking about, what are they working on and what do they want from you? And some of them want to be chased because they don't feel like anyone else is paying that much attention to them.
Holding them accountable, yeah.
Thank you.
I remember. Do they take the couch when they call you?
They take the couch after we make the contract. So I do the contracting sitting up.
No, yes, but when they call you from a foreign country, do they take the couch?
Oh, yeah.
How do you know that?
I hear the squeaking.
That's very.
I see them turning the Skype. So we say hello on Skype.
Oh, in Skype.
We see the picture or Zoom. And then we turn so I turn the camera so that they see outside my window as if they're lying on my couch.
So it's Skype. It's a video call.
Yeah.
Pass it back up to her.
I
remember calling my emailing my therapist with begging for Skype when I went home. It's so stressful. It's just...
Yeah, if it's too stressful, it's not worth it. Yeah. Yeah.
So when you're away, therapy might be needed.
Yeah.
Anyone still has Muriel Diamond article?
I think that came back up.
It's here. I'll pass it back to you. She looks at a lot of sociocultural factors as well, which is pretty interesting, and reviews different theorists. Okay, the 2-year drop-off, raising the fees and moving the location. So, if you're working with long-term patients, every few years, everybody's cost of living is going up. Your expenses have gone up. Their expenses have gone up. Hopefully their salary has gone up. If not, you should be helping them with that. And it's appropriate to raise somebody's fee if the fee is too low for the circumstances that you're both in at that point. So if you started with somebody at the therapy center at a copay, sort of a fee at $20, and you find out that they used to pay $200, you have to look into it. You have to treat it as a clinical issue. Or if they got a better job and suddenly their circumstances are changed, you can say, would this be a good time for me, or this sounds like a good time for me to introduce the idea of raising your fee. And then you talk about it some more. Feelings, usually miserable feelings come up, hateful, betrayed, outraged feelings come up, right? People don't want to pay for therapy. They want you to talk to them because you love them. The fact that this is your career and you need to be paid introduces your need into the situation, and it's an outrage. And you have to be trained and supervised to accept the hatred and outrage and protest and all of the things that come up for people very legitimately in these kinds of situations. And in the Muriel Diamond article and in another one, there are a couple of really good case examples about this.
Well, what if they know that you're charging another patient less who's in an almost similar circumstance, or just something like that?
Well, if they're in a similar circumstance, why are you charging them less? Why aren't you raising both of them?
I don't know, you might be at a different point in the... I'm not sure. But.
So you might have seen somebody for 5 years and you've only seen this person for 1 year or something like that. Yeah, so they're not in a similar circumstance. So you explore that. They say, how come, so-and-so doesn't, I found out that so-and-so doesn't have to get a fee raise. Are you just raising my fee? So you explore what that means. You work with everything that comes up, including silence. You may get the silent treatment for a while. I once had to ask somebody, how many weeks am I going to get the silent treatment? And he said,
And he pays for the silent treatment.
oh yeah, the silent treatment is so fun. It's so gratifying.
Can you do something else, like writing?
You could, but it's better to be present and be experience what it's like. The person needs to put into you whatever feelings they need you to have in order to understand them. So if you're, making your grocery list while they're giving you the silent treatment, if you have to do it to survive the session, do it. But if you can possibly just stay there and feel what it's like, you're going to understand them better, and you're going to learn something about your own tolerance for that deeper work.
Dr. Wagner, how do you communicate this to the patient that if they got, let's say, if they got promotion, right? Promotion, and then you introduce to raise the fee, and how do you communicate that it's also therapeutic, not just you being selfish or interested in the money? Like,
you don't introduce the idea that it's therapeutic. You work with what they bring up. You don't introduce any ideas unless you've determined that that idea is going to resolve a resistance of theirs. So what we're doing really is resolving a person's resistance to telling us everything they need to tell us in order for us to understand why they're suffering and help them with that. That we're not being paid to like them, be nice to them, be mean to them, make them change, any of that. We're being paid for the time that we're reserving in our schedule, every week or twice a week or whatever it is, that we're going to be there listening fully and devoting our attention to understanding that person. That's it. And we're not introducing any ideas unless the person needs that idea in order to say more. Does that make sense?
Yeah.
Okay.
Can we backtrack for a second to paying patients or finding patients? When you were a student at BGSP and you had your patients here, have they stayed with you as a therapist? Were you able to kind of continue that relationship post-graduating?
Yes. The patients that you are assigned or that you bring into the therapy center here, you're allowed to keep after you graduate and so on. So yeah, building a private practice and learning how to do that is part of the analytic training process at the doctoral level, not at the master's level. There's a lot of information in your packet if you're new to the school about what we're doing here and the various programs and stuff like that, which let me pass these around. So this is my business card, actually. So at a certain point in analysis, I became an artist. Accidentally. So these are pieces of paintings or drawings that I've done that where I had to crop the thing in order to make the image look better. So that's my contact information on the back. If you want to be in touch with me, those are my I ran out of business cards. So this is the thing. Use what you have. I ran out of business cards, and I had to do an event recently at a college classroom, so that's what I did. And I liked it. So
the people like it.
Yeah. It doesn't look like any other business card. What was I answering? Something distracted me. What about all the quiet ladies in the back? Questions? Yeah.
Well, this might be jumping forward, but were you guys speaking about changing schedules?
Yeah. Changing schedules can be a simple matter of convenience for either you or the patient. It can be a matter of resistance. it can be a way to avoid certain feelings. For example, I supervise a case where the patient has a hard time waking up early enough for the session, but since she has so many other treatment-destructive resistances, and we're still trying to help her get in the corral so that she can feel contained enough to say what she needs to say, it's not a good idea to give her a later hour. So the analyst experimented with giving her later hours. It didn't actually work any better. So she needs to stay in that hour and be helped to wake up in time to call it that particular hour. So the analyst is considering and is asking her, should I call you and wake you up in time to get your coffee so that you can come to the session? And you can say that's going way above and beyond, but this person may actually need that much contact, that much initiation from her analyst in order to do that. So on the other hand, your schedule might change, and you might need to, flip your schedule completely. Like in the town where I raised my kids, they had this thing where in the first half of the year your kid was in morning kindergarten, and in the second half of the year they were in afternoon kindergarten. So something like that could happen to you, and you have to change your schedule, and your patients are stuck with you. They have to find something that they can, you and they have to find something you can work through. So everybody's going to have feelings about it, and whatever feelings they have about it are going to be part of what they need to work through to resolve whatever they came there for. Otherwise, it's a non-issue. If it's upsetting, it's important, right?
Have you ever run into any analyst who, let's say he was really tired and he dozed off while you're there, and you recognize that happened?
Have I supervised somebody like that, or did my analyst fall asleep? What are you asking? Did I have a personal experience?
I don't need to know if you had a personal situation like that, but if you knew anyone, and how should it be handled?
It should be discussed as openly as the patient and the analyst can tolerate discussing it. So if the patient can say, "What the hell? You're falling asleep on me," that would be desirable. And if the analyst fell asleep, it would be desirable for him to think about why that was and to work it through. So, stuff happens. And, you just have to buckle your seatbelt and deal with everything if you possibly can. And if you can't, get more supervision. Yeah.
You talked about fee setting on the lower end.
Mm-hmm.
I'm wondering about fee setting on the higher end. How do you think about when to know it's appropriate to charge? Instead of 100, 150, 250, or more? Anything about?
You can get a sense sometimes from the person who's referring you the patient what sort of income range they're in, how much they might be able to pay. You could tell the referring person ahead of time, I'm stuck with everybody at all the levels. I can only take full fee patients at this point. You can say, I said for a while, for many years I wasn't taking anybody at all, so that was kind of easy. But sometimes I would have like 1 hour or something like that, and it would be an inconvenient hour, and I would say, well, okay, we could talk about it, but I'm expensive and inconvenient. And I found that aroused more desire to see me than almost anything else I ever said. So I think that's your point. They got the feeling that I was really hard to get, and they wanted to to fill that 11 a.m. hour or something like that. But if you really don't know the circumstances of the person, You just have to be willing to explore it, and if you want to see people at the higher end of your fee, for whatever reason, you need more money, then you have to just be willing to refer them on or see them less frequently or something like that.
What about if the patient loses his or her job?
If the person loses their job, you can work with them about how you should help them at that point. Should I be helping you get another job? How is this going to affect us? You might say, I would talk it through in the usual way. If they really can't, if they have no backup, they can't have a family member who's going to help them through this, they can't, get a second mortgage and, pay all their bills, then they're really in a catastrophic situation. And you have to decide either to see them and build up a debt, and I would say decide on an amount ahead of time that you're willing to cut the ceiling at, or you could say, I don't think it would be doing you any service to rack up a big debt, until you get a job. Should I call you in a month and see how you're doing, something like that. You can reduce a person's fee if you really think it's good for them and if it's good for you, and talk it through. It's not necessarily an insult to everybody. It's not necessarily a resistance, but it often is. So you just have to be willing to really examine it week by week. Is that a question or a hair thing?
Me?
Yeah?
Both.
Okay.
Yeah. So I was thinking, this might be a little bit off of the topic, but from your experience, a certain level of understanding about psychoanalysis approach helps this help this patient stay or really getting benefits out of the sessions.
Whether the level of understanding of the analyst helps the patient get more, or the level of understanding of the patient about psychoanalysis?
Like the whole approach, how we do sessions in psychoanalytic way.
Whether that psychoanalytic approach,
Sorry, let me frame my question better.
Okay.
So, let's say patient A has some understanding and knowledge about psychoanalysis.
Okay.
And the patient B does not. So, do you find a difference later on? Like, does that determine how well this patient do, and also how long they stay with you?
I don't think so, because if about half of my caseload is non-psychoanalytic students and half is psychoanalytic students, and they're all long-term cases, I would say no, I don't think that knowledge of psychoanalysis in the patient is important or necessary. Knowledge of themselves and of the world and curiosity and all of that is important, but and psychoanalytic students can use what they know as resistance. It has been known to happen.
I'm thinking, I'm not sure about the culture here, but definitely in China, if you don't have any if you don't have any lessons or work with the insurance company, people do consider you as less authority. So do you think it's also the case in the United States that people question your profession just because you don't take insurance?
I'm not sure I'm qualified to answer that because I do have a license. I don't use it for insurance purposes, but I have it. So I don't know. What do people who are not getting licensed? Is anybody in the simple psychoanalytic master's program and not getting the licensable part can answer that question? I think it's kind of culturally assumed that if you're in practice, you're qualified to be in practice. Unfortunately, some people can hang out, a sign that they are a psychotherapist with no training, since that title is not protected, nor is the title psychoanalyst, by the way. So I think it's an individual matter. If someone meets you and gets a feeling for you, the feeling they get for you and from you is more important than whether you're a social worker or an analyst or a counselor, or you have this license or no license. If you're an analyst, you've had vastly more years of training than those other people who have a license. It's just that we don't have a license. So I think people figure it out.
What do you mean when you say you don't have a license? Like, you graduate here and then...
Psychoanalysts don't have licenses. So the way most psychoanalytic institutes handle that is to not accept candidates who don't have a prior mental health license. Our school accepts people at the master's level for a licensable program and a non-licensable program at the master's level. So our students can elect to get an LMHC with our training. They can then apply to the state for that license. And some do and some don't. And then at our doctoral level, you can get a doctorate in psychoanalysis and be a certified psychoanalyst, which is the highest analytic credential, but it's not a licensable degree or credential.
Does Vermont have a license?
Yeah, Vermont, New York, New Jersey. Some states do have a psychoanalytic license. And in Massachusetts, we've been working on it over the decades and not getting anywhere.
What about Medicare? Is this SID degree allowed to take certain more types of insurance?
No, the SID, the doctorate in psychoanalysis, does not necessarily entitle you to take insurance. In some states, it works, like in Vermont. Sometimes it works. In New York, if you have a New York state license, you can, in some cases, accept insurance in New York. But it's very much state by state. You can't assume that with a doctorate in psychoanalysis, you'll be able to get a license in Massachusetts.
But LMHC, what about LMHC?
LMHC you could get with our counseling degree.
Yes.
And the exam and all the internship hours and stuff like that.
But proceeding to next degree will not give me more benefits in terms of insurance.
No.
What about if you move to another state?
Hang on a second. I'm working.
Oh, this is, if you want to ask first, this is on a different, different question.
Thank you. What about if you move to another state, for example, once you got your license?
You have to look at their reciprocity laws. And if you're thinking about moving to another state, look at them in advance, because you might be better off getting licensed in that state in the first place, so that you don't have to take the Massachusetts exam and the California exam. Some states have reciprocity and some don't.
My question is, how do you move from having, been in a practice where you accept insurance, and you've done this for years, and are beginning to want the freedom of not accepting insurance, and if you know anybody who's made that transition, how to do that when your practice is full, and how to do it mindfully.
That's when to do it. When your practice is full, that's the best time to do it, because then you can just not take any more insurance people after that point.
I guess my fantasy is that everybody will, or half of the people would leave me.
Well, you can still take their insurance, and then the next time you have an opening, you take somebody who pays you more than what you would get from insurance if you used them the insurance.
So the contract with the insurance companies is actually that once you are on their panel, you have to renounce them, and you can give them that 3 months period before you can start advertising as not taking insurance. So I cannot take a new patient that, say, has Blue Cross Blue Shield if I already have another client who I'm charging through Blue Cross Blue Shields.
Why can't you not have any more slots in your practice, in your fee structure for insurance people? Why can't you say to the next person who calls you that you're no longer accepting insurance
You're full
referrals?
for that.
Yeah.
Oh yes, I could do that, but I would have to stop taking insurance from my current.
Well, that's what I don't get.
It's just the contract that you make with, when you sign with the devil. Like if you are taking, you basically have to honor, you cannot pick and choose your, if you accept another client that has that insurance, you also have to accept their insurance. So once you give that away, you give everything away. So it's just, it's bizarre. I think I so much would have loved to start like you did without insurance, because it feels like a crutch that I'm, not that willing to give up.
Wow. This I have never heard. So it's considered you're breaking the contract with the insurance company if you keep the patients that you already have on that insurance, but you cap it and don't take any more people on that insurance. Is anybody else in that situation? You are?
I think you can say that you're planning to stop.
Yes, but then I will have to stop.
Right.
Yeah. So I can say in 3 months, I will not accept your insurance anymore. That's fine. And I'll stop taking insurance for the entire population. And some people might be still able to come once a month at a reduced fee, like you were suggesting, great idea. And then I will be on my own.
Yeah.
Except out of pocket. And it's a new universe. It's like you are used to driving and now you have to fly. And I don't have a pilot's license. So my fantasy, I have to write a few books, get really popular, and then
you have to get a waiting list. You have to get a big, long waiting list and probably do a bunch of time-limited groups scheduled for that 3-month period. You need a large volume of the kind of patients you would enjoy treating, probably in groups, and you'd probably have to do some specialized marketing for that. So that in that 3-month period when you're biting that bullet, you have a lot of potential people who might want to work with you, and then you're going to be learning how to negotiate fees with them and stuff like that.
It's like learning to walk again.
Yeah. That's terrible news.
Oh, they're smart.
Oh.
How to catch you.
Oh boy. Okay, last couple of questions. Yeah.
What's the length of argument when you initially get a patient in terms of determining fit? Do you ever turn people away and tell them that you don't think the fit is good, or do you initially kind of accept anyone or most people who come in for that first session?
I don't take more than 2 borderlines at once, if I can possibly avoid it. I don't take psychopaths. I don't take gun owners. I don't take suicidal patients. And I'm very confrontational about that.
What do you tell them?
That if they're not planning to stay alive, I'm probably not the right person for them to be working with. If somebody I'm already working with is going to start threatening suicide, then I work with that as a threat, as a threat and a hostile communication, a hateful act, and so on. And I would even go so far as to say to somebody, "Why should I waste my time with you if you're going to just go and kill yourself? I have better things to do."
Do you provide people with...
She said, "Oh my God."
Do you provide people with referrals to clinicians you know would take
I send suicidal people to a clinic.
Uh-huh.
Yeah. And I'll sometimes say, I don't think I'm the right person to help you in private practice. I think it's better to be with an agency that has more backup and more resources than a private practitioner, that kind of thing. And I do try and responsibly refer people to somebody I know who can help them better.
How do you figure out gun owners?
Ask them.
Do you ask that during the show? Okay.
How do you know they are borderline in an initial week?
Well, a lot of times you can't tell, but after you've been in practice 40 years, you can sort of see them coming. Yeah, you have to use your instincts and your experience, and sometimes you get fooled. Yeah.
Hi. So I understand from just the discussion here that there are a lot of issues with insurance that people aren't really that excited to be working with insurance companies. I guess in my mind, I always thought of insurance as like this kind of thing that levels the playing field so that people who weren't necessarily financially well off could, also afford analysis. I guess I'm wondering if, let's say, I kind of like forego the whole insurance thing and decide to, do a private pay. How would I design my practice so that I wasn't only catering to like people in like a specific kind of financial bracket?
Yeah, you'd have to set your fee scale so that you could take a certain number of people at, for example, what they would be paying for a copay if they were able to use their insurance. If that's actually all the person is able to afford to pay, and they would have to pay that to somebody else as a copay for their insurance, and you can afford to see them at that fee and you want to see them, that's a perfectly respectable fee to see somebody at.
And there's always a therapy center.
And there's always the therapy center, yeah. So you can, if you're at a stage where you can't afford to see, and let's say you have 5 people at a $20, $25, $30 fee, and you need to pay your bills and you need to accept higher referrals, at that point you can refer them to the therapy center, still in good conscience. Yeah, I don't like to just see rich people. It's kind of, I don't like it. And so you have to know yourself well enough and what populations you want to work with and how you can make that work for them and for you.
Well, I know for myself, when I was younger, I would deal with the Medicare or the insurance, because it really goes against my brain not to accept insurance. I mean, I wouldn't like it if my physician tomorrow told me, oh, I'm not going to accept insurance anymore. I'd be furious. But I'm at the point in my life where I had to deal with Medicare for 10 months to get paid. It's like, I've done this enough. So what happens? If it works, I'll do it. Otherwise, I won't. But if I was your age, I would take insurance. That would be, because it sounds like you'd be conflicted if you weren't taking insurance. I need to love insurance.
And you can do some of both.
Yeah.
You
Well,
can
you
also do some of
sometimes
both.
can. Remember what she said?
Well, you can take like one type of insurance that pays well, or that a certain population is likely to have. Let's say you want to treat, teachers, and the teachers union, provides that kind of insurance. You could take that one insurance and rule in a bunch of worthy people that you want to treat, and not take any other type of insurance. There are ways to figure out how not to lose your social conscience. So we're out of time, right? Okay, so this is the registration. So I have a sign-up sheet on the way out. If you're interested in being contacted about the 3 follow-up sessions, which are at this time on 3 Friday evenings, sign here. If you want to look at these 3 books, they're called Getting Better at Private Practice, Mastering the Financial Dimension of Your Practice, and the Private Practice Handbook. Look at these. They're going to be in our library, and Amazon has them.